Good morning, everyone, and welcome to our third Primary Care Snapshot Workgroup meeting. I'm Debbie Lindis, Healthcare Delivery System Group Manager at the Office of Healthcare Affordability, or OCA, within the Department of Healthcare Access and Information, or HCAI. I use she, her pronouns. And during today's meeting, we'll start with a brief review of meeting logistics, and then I'll provide an update on the workgroup charter. Next, we'll review our approach to selecting and evaluating primary care snapshot indicators. And then we'll discuss proposed indicators in the investment and workforce domains. And after that discussion, we'll close with the next steps. As just a quick reminder, here are our workgroup members and the range of stakeholder perspectives they represent. And just as a brief recap of our meeting format, we appreciate and consider all the thoughtful comments from all attendees at this public meeting. Workgroup members may offer verbal feedback or make comments in the chat. And we ask that non-workgroup members offer any feedback they have through the chat or provide written feedback to the OCA team after the meeting. And please, all commenters, we appreciate when you provide your name and organizational affiliation when you make a comment. Though we may not be able to respond to all comments during the meeting, we will review all the chats and use them to inform our work going forward, so we really appreciate them. And I just wanted to briefly note that the July 8th workgroup meeting conflicts with the Affordability Advisory Committee meeting, so we'll need to either adjust the time or the date on that one. And then on the November 11th meeting, will need to be rescheduled due to the Veterans Day holiday. So we'll follow up with the rescheduling plans for both of those meetings very soon. So to start off with the charter, workgroup members did not provide any feedback on the proposed workgroup charter. And so the HCAI team will move forward to adopt the charter as proposed, and we'll be posting the final charter to the workgroup webpage by the end of this week for reference. So next on our agenda is reviewing our approach to selecting and evaluating primary care snapshot indicators. So this slide shows the process we're following to select indicators for the snapshot. We've completed the steps in the gray boxes. First, creating a primary care indicator inventory of example state and national indicators across the 5 domains to inform our indicator recommendations for each snapshot domain. Then we reviewed and selected high priority indicators from our inventory that relate directly to primary care and meet our evaluation criteria. And the green box on the right encompasses where we are now in the indicator selection process. At the January workgroup meeting, we began our discussion of recommended indicators, starting with the investment domain. And once we review the recommended indicators or other indicators that the workgroup may propose against a set of evaluation criteria, we'll choose a concise set of indicators for each domain to include in the snapshot. And we'll be reviewing those evaluation criteria in just a moment. So the indicator inventory includes over 100 indicators across the 5 domains from California state agencies and state or national policy organizations. Indicators are from a variety of data sources with California-specific data, such as the Healthcare Payments Database, or HPD, survey data, and professional training data. And they cover a range of populations from specific markets like Medi-Cal or commercial, or statewide. And as one example, an indicator for the investment domain is primary care investment as a % of total medical expense. And we'll go into more detail on the slate of investment indicators we're considering in just a few slides. These are the criteria we'll use to evaluate whether an indicator is the right fit for the snapshot. And we've included some additional context on why it matters for each criterion based on the workgroup's feedback from last meeting. And the information on this slide, along with additional details, can be found in the domain and criteria background document we shared with the workgroup last week for your reference. And we encourage workgroup members to use those materials as you're reviewing the proposed indicators during today's meeting and when completing the post-meeting indicator survey, which we'll explain in more detail a little bit later in the meeting. So the first criterion is whether the indicator is of interest to and actionable for California stakeholders. The snapshot aims to generate insights to increase stakeholders' awareness of the challenges facing the primary care sector in California and inform efforts to strengthen it. The second criterion is whether the indicator can be developed using existing and accessible data sources with California-specific data that can be tracked over time. By utilizing existing data sources, the snapshot aims to minimize duplication of effort and support measure alignment. Data sources for the snapshot should be timely, complete, accurate, provide appropriate granularity, and should have been used for similar analyses and also likely to be available in the future. The third criterion is whether the indicator directly measures the strength of the primary care sector. This is important since there are many indicators that are related to or impacted by primary care, but do not provide direct insight into the strength of primary care itself. The snapshot should include indicators in which improvements in the primary care sector likely would result in improved performance on the indicator. And the final criterion is whether the indicator can track change within the primary care sector within the 5 domains. Transparent, longitudinal reporting on the primary care sector helps identify barriers to high-quality primary care and potential policy solutions. The snapshot will focus on advancing these aims, not on measuring the performance of specific providers or health plans. And for some additional context, the primary care snapshot will report both existing and new analyses from California and national data sources with actionable data for California. We'll work with departments across the state and national subject matter experts to align methodologies for analyses with state and national best practices when possible. And we'll also update reporting to align with OCA's primary care definition to the extent feasible. And I do just want to note that although the primary care snapshot may and almost certainly will include new analyses of existing data, new data collection is not a part of the snapshot initiative. And this is something we'll continue to emphasize as we evaluate proposed indicators. The snapshot aims to capture team-based primary care using OCA's primary care definition. For example, for the investment domain, the OCA definition includes billable care team members like physicians, physician associates, nurse practitioners, community health workers, and FQHCs when they are identified on claims. And OCA's non-claims primary care definition also includes payments that encompass services provided by the entire primary care team, for example, practice transformation payments. For other domains, HCAI will use OCA's list of primary care provider taxonomies, places of service, and services where feasible to define primary care. So for example, a primary care clinician density indicator would use OCA's list of primary care clinician taxonomies. And now I will hand off the presentation to my colleague Miranda Wirtz, our senior primary care specialist, to review proposed indicators in the investment and workforce domains.
Great. Thanks, Debbie, and good morning, everyone. Our next agenda item is to continue our discussion of primary care snapshot investment indicators. But before we discuss the specific investment indicators, we want to provide background on the investment domain as requested at the last workgroup meeting. This information is also included in the domain and criteria background document shared with workgroup members with the meeting materials last week. So for the snapshot, The investment domain describes the financial resources spent to strengthen the primary care sector and deliver continuous, comprehensive, and coordinated primary care. This domain is important because increased investment in primary care is associated with better quality of care and more equitable outcomes. Historic and ongoing underinvestment in primary care is considered a key factor in the poor performance of the U.S. healthcare system compared to other high-income countries. This investment has important consequences for access to primary care and for population health. Additionally, focus on this domain is important because fee-for-service payments remain the predominant funding stream for most primary care providers, despite national efforts to move to value-based payments. Some example policy questions about primary care investment are: how much is spent on primary care? What payment methodologies are most frequently used by insurers to pay providers for primary care? And how is spending on primary care changing over time? Also, as a follow-up from our discussion at our last meeting on other investment data sources, we looked into data sources related to physician compensation and practice structure that were suggested. The first was the American Academy of Family Physicians Family Medicine Career Benchmark Dashboard Survey data on family physician compensation. Concierge medicine was also mentioned as an area of interest. We identified this second data source on the slide from a recent Health Affairs article on concierge and direct primary care, which used proprietary data and manual review of publicly available information to identify a subset of direct primary care providers and practice ownership. After consideration, these data sources do not meet criteria for inclusion in the 2026 snapshot. The AAFP data only includes family medicine physicians and not other OCA primary care providers, so the data is not representative of team-based primary care. The concierge data is not complete nor easily accessible to HCAI. HCAI is also not clear on how to interpret changes in concierge medicine as a reflection of the health of the primary care sector. HCAI appreciates these suggestions and will continue to explore whether or how data on physician compensation and practice structure should be incorporated into the snapshot in the future. We have also considered two data sources since our last discussion related to the number and salaries of physicians. The first is the American Medical Association's Health Workforce Mapper, which uses their master file and national plan and provider enumeration system data to report on physician and non-physician healthcare workforce counts, location, practice type, gender, and age. This data is only available for 2021 and includes measures like population per provider ratio and count of providers. The data is available for many of the primary care provider types included in OCA's primary care provider taxonomy list. A benefit of this data is that it may be stratified by geography, physician practice type, physician employment type, and physician age. The second is U.S. Bureau of Labor Statistics Occupational Wage Statistics survey data on mean annual wages for most primary care team members. This source has data available going back more than 20 years and includes jobs per 1,000 and mean annual wage, which can be stratified by percentile. These data sources may support indicator development for future iterations of the primary care snapshot, and we will continue to explore whether and how to present data on workforce demographics and compensation. So these are the potential investment data sources we have identified for the snapshot. The proposed investment indicators rely on this first data source, OCA's primary care investment and total medical expense, or TME, data collection. OCA has just completed the first round of primary care investment data collection and is expected to report on the data this year. This data will be available in aggregate for all payer types, but will not be able to be stratified by geography or demographics for the snapshot. Another investment data source we considered is the HCAI HPD, which has granular data available for most payer types and can be stratified by geography. However, the HPD does not yet include non-claims data, limiting the type of primary care investment we could include in the snapshot. We also considered the Integrated Healthcare Association's health plan data, but it is not readily publicly available and is limited to commercial, Medicare Advantage, and Medi-Cal data. However, this data does include non-claims and geographic data. And then lastly, the Medi-Cal rate development template also includes primary care investment data, though this is only for Medi-Cal and not publicly available. The definition of primary care for rate development purposes also differs from OCA's definition. So to identify the proposed investment indicators, which we'll jump into after this slide, we first reviewed 19 primary care investment indicators included in our indicator inventory, which come from California and national reports, some of which are shown on this slide here. Many of these indicators were similar variations, and our review identified 10 unique indicators. Of these, we identified 4 to consider for inclusion in the 2026 primary care snapshot. So at our last meeting, we began discussing the 3 indicators on this slide for the snapshot. The first is primary care investment, both as a % of total medical expense and on a per member per year basis. The second is change in primary care investment year over year. And the third is primary care investment broken out by claims and non-claims payment categories. All these indicators will use OCA's primary care investment and total medical expense data, which I mentioned on the previous slide. And this data will also be used in OCA's separate evaluation of progress toward the primary care investment benchmark. We propose stratifying the data for each indicator by payment category, like primary care paid via claims or specific non-claims categories, such as incentive payments or capitation, and by payer and product type, such as commercial HMO versus PPO, Medicare Advantage, and Medi-Cal managed care. For the snapshot, we do not intend to report on these indicators by specific payer. We feel these indicators meet all 4 of our proposed evaluation criteria, which are listed in the table with our justification. The examples of these indicators that we reviewed at our last meeting are provided in the appendix for reference. In addition to the first 3 investment indicators, we are also considering including cumulative change in primary care spending relative to other service categories like hospital inpatient and professional specialty as an investment indicator. This indicator could provide insight into the extent to which redistribution of spending from higher intensity service categories such as inpatient toward high value primary care is occurring. OCA data could be used to calculate this indicator, and we believe it meets all 4 of our evaluation criteria. To get a sense of what reporting on this 4th investment indicator could look like, here is an example from Utah. One Utah Health collaborative included the cumulative change in total medical expense per member per year from 2021 to 2023 by market and category, including professional primary care, which is in the box on the slide. OCA could provide a similar graph that shows cumulative change in primary care spending relative to other service categories. So with that, I'll pause here for some discussion. And whenever you speak up for discussion, we welcome you to introduce yourselves with your name, role, and organization. So these are our two guiding discussion questions. Do workgroup members have any questions or feedback on the proposed investment indicators? And additionally, are there any other key investment indicators members would like us to consider?
Miranda, I think there's a question from Diana in the chat.
Okay, yeah.
Yeah.
Go ahead. Debbie, do you
Yeah,
want to take that?
Sure. Yeah, thanks, Diana, for that question. Will commercial market be stratified between Kaiser or non-Kaiser? And I'd say for the snapshot, we plan to report by market to start, and then depending on interest, we could potentially report by payer, but our main intention is to report by the overall market categories. Happy
Thanks.
to hear any.
Yeah, I do. If possible, I think that should be considered because we just often see such a difference between, not necessarily just between HMO, PPO, but between Kaiser and non-Kaiser, that it can skew the overall picture. So I think it would be great if that was possible or could be considered for future.
Great, thank you for that feedback. And then I think Kevin was next.
Great, thanks, Debbie. This looks great to me, first of all. I think these are really well selected, and I like that you have both, as a percent and in the absolute per member per month spending framework. So these look really good. Initially, I think you mentioned in the slides this whole idea of stratifying, and I remember at our last meeting, this was something that came up quite a bit, was to look at distinct particularly populations and looking at less well-resourced, more well-resourced. So it seems like with, I think in that initial slide, you made it clear the HPD, the claims database can get down at the granular level, but it doesn't include non-claims data. So you're using the, primary care spending and total spending reports. So it sounds like those can be stratified by plan type, but not by geography or some of the other types of enrollee characteristics. Am I correct, Debbie, in understanding
Yes.
this?
Yeah, that is correct. So OCA collects data from plans and can aggregate that to the product type level, but we do not have geographic information that's available in the OCA data collection. HPD can do that. So that's something we can consider in the future.
Yeah, I think being realistic about what's available and how much work it takes to go back to the sort of raw claims data reports. And then the issue with HPD, then you have the non-claims data, which are then not in the health plan database, right? Health payment database. So it's tricky, but it seems maybe just for ongoing future work that would be something to continue to aspire to achieve, would be to see how there's a way to put some other filters on this. But again, I think this looks very good as the initial step.
Thank you for that. And I think, Eric, are you the next one with your hand up?
Yeah, I think so. As I think the token pediatrician here, I wanted to just put out a word for us and wanted to see if there is a possibility or an expectation that we will have different data for pediatric primary care versus adult primary care. I know the investment in children in primary care tends to be a lot lower nationwide, and I'd love to see that reflected in the data if that's at all possible.
Thank you. That's great feedback. And I think right now the OCA data is not stratified by age. That was something that we thought about when we were setting benchmarks initially. And the burden on data submitters of the plans is high with every stratification we ask them to do. So so right now for 2026, that's probably not available, but great consideration that in future things like using the HPD allows us to get at a much more detailed level for various stratifications. So thank you for that. And I think Ed, you're next.
Yeah, thank you so much for sharing. I really appreciate the start and kind of the more detailing with the questions and the feedback. One of the things that I was wondering is, do we at some point plan to set some type of visible benchmark or target? I know there's a target for spend. This is just more along the lines of, how we're comparing, let's say, to all the other states in the US. Is there a need potentially to see California's performance through this snapshot in relation to other states, just so that we can maybe contextually see how we are either better performing or have opportunities to improve when it comes to primary care spend?
Yeah, that's a great consideration. Right now, we don't have a direct benchmark, a comparative benchmark in mind, but would love to have more conversations with the work group about that. Certainly, there are, I think, around a dozen other states that have public reporting on their primary care spending. So we could incorporate comparisons to other states. However, definitions, the devil's in the detail, and different definitions have different measurement and so levels, and so that is a challenge that each state has its own definition. But great point. Thank you. And Jeremy.
Good morning, thank you. I wasn't completely clear on the inpatient data and how what the plan was as far as trying to parse out the primary care that isn't going to inpatient. Is that kind of the gist?
Oh, yeah, great question. So for the comparing across the categories, let's see, Miranda, do you want to just go back to that slide for a quick second? There we go. So the idea here would be to look at the growth rate of primary care spending, which is essentially all it's professional spending in outpatient settings and by primary care providers, and then comparing that to the growth rate in other service categories such as inpatient. So it wouldn't be trying to figure out how much hospital care is primary care. It would be,
right.
How are they growing compared to each other? Is that, I'm not sure if that answers your question.
Yeah, that helps. I'm just trying to think of a way, we all know that when a healthy primary care sector is keeping patients out of the ED for things like medication refills and simple things like that. I don't know if there's a way to use claims data, ICD-10 codes to kind of parse that out at all. But it's just a thought, is that, I get ED follow-ups and the only diagnosis code that's used is encounter for repeat prescription, like basically they went in for a metformin refill. And so if there were a way, obviously some clinicians are going to code that very differently so I'm sure it'd be variable and hard, but yeah, just wanted to see if there is any interest or ability to kind of parse that out. Thanks.
Yeah, thank you. And when we talk about access and quality indicators at a later meeting, HCAI does have data on avoidable emergency department utilization that we can include, which is separate from investment, which is this indicator, but we do have ability to look at things like avoidable emergency department use. And then this indicator is intended to kind of track that progress towards that redistribution that we hope to see, where we have more investment in primary care, and that hopefully leads us to see less growth in, for example, hospital inpatient and emergency department. Thank you. Are there other questions or comments? I have not been tracking the chat. If there's anything else that people want to talk about live, please go ahead and chime in now.
Yeah, Debbie, I just wanted to flag quickly that Catherine shared that Massachusetts does include MD and DO salary using state-specific data from the BLS. She's just wondering if we're considering using this methodology. I think it's possible. We're definitely referring to Massachusetts and what they've done so far for guidance. So something we'll look into more closely. I don't know if you have anything else to add to that, Debbie.
No, I think, yeah, we will definitely look into that and appreciate that Massachusetts is reporting on that. We'll be interested as we go forward in getting more input from this work group on how and what clinicians' salaries, how does that, do we want that as an absolute amount? Do we want those as comparative to other specialties? What does it mean to report on clinician salaries? So we'll definitely come back to that and appreciate the flag there. I see Carlina.
Thanks so much, Debbie. Carlina Hansen, California Healthcare Foundation. So I recognize that you're not going to be collecting new data as part of the snapshot, but I would imagine you're going to find areas where there's data you really want, and the sources are weak. So I'm curious if you're going to be putting a pin in sort of top priority items to identify places where the data could be either improved or claims data is lacking for potential further action. And I'm thinking specifically in the context of the previous slides around workforce indicators, where you're talking about team-based care, and some of those things are just not collected on claims. So it would be difficult to actually identify some of the data that you're hoping to get.
Yes, that's a great point. And we definitely will be tracking areas where we are seeing gaps and opportunities for either HCAI or other organizations to enhance data collection in the future that can shed light on important areas that are, yeah, thank you.
I think that's all the questions in the chat. And yeah, there's just been a little more discussion in the chat about Massachusetts and their reporting on family medicine physicians and pediatricians only for salaries. So there's a great conversation going on in the chat. If there are no other discussion questions on investment indicators, I'll move on to next steps. And thanks, Debbie, for fielding all those investment indicator questions. I know you are very in the weeds on all of that for our other work. So, okay, I'll move on to next steps. So a few items here. First, we ask that work group members complete a survey on their evaluation of the investment indicators against the criteria. We will be sharing the survey and a rubric for evaluating indicators against the criteria we have reviewed, and we'll send that later this week. And then once complete, we will review the results to inform the final list of indicators. Then we will develop technical specifications for the indicators that will be included in the 2026 snapshot. Okay. So the next domain we will discuss is workforce. But before we dive into the indicators themselves, I will start again with some background on the workforce domain to inform our discussions on the proposed indicators. The workforce domain describes the supply, geographic distribution, diversity, and demand for individuals on the primary care team, including primary care clinicians, expanded care team professionals, and community care team members. For snapshot purposes, primary care clinicians refers to physicians like MDs and DOs, nurse practitioners, and physician associates. This domain is important because high-quality advanced primary care requires well-rounded primary care teams. Additionally, while California's primary care workforce is growing, it is not yet able to meet all needs. Examples of questions about primary care that would fall in the workforce domain are: how does the primary care workforce supply compare to demand? How are supply and demand changing over time? And what factors impact supply and demand of the primary care workforce, including retention? So far, HCAI has identified the data sources here as potential workforce indicator data sources. The first is HCAI HPD data, which can identify primary care providers using the OCA primary care provider taxonomy list and stratify the results by geography. The second is the HCAI Workforce License Renewal Survey, which is available to HCAI but does not specifically collect data on primary care physicians. The race and ethnicity, language spoken, and education pathways data is published in aggregate by license type. A major limitation of this source is that the data does not include whether a provider is actively working in primary care. The American Medical Association could be an alternative source for aggregated physician demographics. The third potential workforce data source is Accreditation Council for Graduate Medical Education, or ACGME data. This data is publicly available and identifies many primary care specialties, but does not identify all OCA primary care providers or non-physician team members. The ACGME includes physician residency positions and, most limiting for snapshot purposes, cannot track whether a provider eventually practices primary care after residency. Along with the sources listed, we considered data from the American Medical Association and the U.S. Bureau for Labor Statistics for aggregated physician demographics, as we discussed in the investment section. While these sources do not include all of OCA's primary care providers, they may shed light on provider demographics. So to identify the recommended workforce indicators we will discuss shortly, HCAI reviewed 30 primary care workforce indicators from California and national reports. Many of the indicators reviewed were similar variations, which we narrowed to 24 unique indicators. Of these 24, we identified 4 to consider for inclusion in the 2026 snapshot. The first recommended primary care workforce indicator is primary care clinicians per 100,000. We propose to stratify this indicator by market, payer, and/or product type, as well as by geography and primary care clinician licensure to highlight the workforce across physicians, nurse practitioners, and physician associates. Additionally, we are considering stratifying by community level of social need, as defined by the California Healthy Places Index score, or Milbank's Social Deprivation Index, to understand equity across the primary care sector. Just a quick note that when an indicator in another domain may shed light on equity across the sector, like this one, we will highlight these for the work group during the discussion of the domain. We believe that this indicator meets the criteria for inclusion because a high-quality advanced primary care sector requires a well-distributed supply of practicing primary care clinicians. In future iterations of the primary care snapshot beginning in 2027, we will likely be able to use data from the HPD for this indicator. For 2026, we would include the most recent California data from the Milbank Primary Care Scorecard. This indicator directly measures practicing primary care clinicians through delivery of primary care services on claims. In terms of tracking changes, we can monitor changes in primary care clinicians in California and shifts in types of taxonomies providing primary care services. For the snapshot, HCAI could develop figures and infographics like these on the slide from the Massachusetts Center for Health Information and Analysis, or CHIA. In their primary care in Massachusetts dashboard, here CHIA reports primary care physicians, physician assistants, and nurse practitioners per 100,000. This data revealed that while the supply of primary care providers in the state increased from 2022 to 2023, the share of those providers who were physicians decreased slightly, highlighting the importance of team-based care. And then to get a sense of what stratifying this indicator by community level of social need could look like, here is a figure from the Milbank Memorial Fund's 2024 Health of U.S. Primary Care Scorecard. So for their analysis, Milbank defined high needs areas as those above the median social deprivation index score. So this data shows that across the nation, primary care clinician density is higher in areas higher on the social deprivation index. So it's that orange line is the high social deprivation index, and the gray line below is the low social deprivation index, and then the dashed line is the median. We are also recommending including new primary care physician residency positions and percentage of primary care physician residents trained in community-based settings as snapshot workforce indicators. Understanding the physician pipeline trained in community-based settings also sheds light on the equity domain, as clinicians trained in community settings are better equipped to treat community members. HCAI would use data from the Accreditation Council of Graduate Medical Education to report on these indicators at the state level. Both of the indicators directly measure residents focused on primary care, enabling them to enter the primary care workforce. Both indicators also track changes in the supply of primary care physicians in the state. New primary care residency positions help create a sustainable pipeline that can ensure a workforce supply capable of delivering high-quality, advanced primary care. The percentage of primary care physician residents trained in community-based settings is of interest to stakeholders because a healthcare workforce trained in community-based settings are more likely to practice in those settings. HCAI has also considered similar data on nurse practitioners and physician associates training and postgraduate fellowships focused on family medicine. HCAI has found that data on such programs may not be readily available or accessible, but will continue to explore for future iterations of the snapshot. We also welcome any suggestions for data sources from the work group. So HCAI could build on previous reporting of new primary care residency positions in California from the California Healthcare Foundation. While California did not meet the Future Health Workforce Commission's goal for 2023, which is here in this graph, HCAI could use the same ACGME data source to report on new primary care residency positions since 2023 and moving forward. HCAI could use the data from Milbank's primary care scorecard data dashboard shown here to report percentage of primary care physician residents trained in community-based settings. The California data from Milbank can be stratified by a narrow or broad definition of community-based settings. The figure on the slide shows data using a narrow definition of community-based, which refers to programs with a rural training track or Health Resources and Services Administration, or HRSA, teaching health center graduate medical expansion grants. The data using the narrow definition shows that California, the lower solid line, lags behind the nation, the dashed line in residents trained in community-based settings, highlighting a potential opportunity to focus primary care residency expansion efforts in community-based settings. HCAI envisions including data for both narrow and broad definitions of community-based settings into the snapshot. We'll pause here again for any questions or feedback workgroup members have on the proposed workforce indicators. In addition, we would appreciate workgroup members highlighting any other workforce indicators or data sources we should consider including in the snapshot. And I will call on Raul first.
Yeah, hi, Dr. Raul Ayala from Adventist Health. One area of addition I didn't see on the activity for physicians, whether they were part-time or not. Did we think about medical board data? So when we apply for our licenses or renewals, they ask all these types of practice and full-time equivalent or et cetera. Was that considered?
Yeah, I can speak to that question. So the license renewal surveys do ask questions about what percentage of time you're spending in patient care, but they do not distinguish between your specialty and whether you're practicing primary care or not. And so, for example, internists, they don't. That data does not include a clear designation. Are you a primary care internist or some subspecialist? And so that's the challenge with using that data right now.
We might want to look at that survey because I just renewed my license and it asks me things like family medicine, community medicine. Where am I working at? Is it a clinic? Is it a rural health clinic? Is it? So I'm just, if there are other data sources, I thought of that one because I just did it. The other thing is I do want to accent the formula is great on the 100,000 per. I think that formula is being used more regularly, and I love the graph of distinction. I had two questions. So when we say primary care, and you mentioned nurse practitioners, PAs, et cetera, as a team-based care, love that. But do we have a distinction of what primary care is? Who falls into those specialties? Do we have that?
We do. So OCA has a definition of primary care that includes a really specific list of taxonomies, physician taxonomies, nurse practitioner, and physician associate taxonomies. We'd be happy to share that list, but we've gone through that and with stakeholder input to select the taxonomies that we think reflect folks who practice primary care versus more specialized care.
Perfect. Yeah. And then one, I know I had 2 to 3 questions. One last one, I promise. When we say community-based settings for training, does that include rural health and rural hospitals and rural designations? Because the definitions may be different of what you're looking at, whether it's, national benchmark or of what the rural rule is. But I do want to make sure that this community-based is not just a community-based clinic system, but we also need to think about if it was already thought about where rural and rural hospitals that are sponsoring or are starting programs that are out in community.
Yeah, that's a great question, Miranda. You may want to add here. So right now, what we're looking at is the Milbank definition of community-based settings, which they have 2 definitions. A broad definition which essentially includes most settings that are not an academic medical center, and then a narrower definition that's yeah, thank you. On the tiny footnote there can show what the narrow and broad definitions are. So the narrow definition is training programs with a rural track or a HRSA teaching health center track.
Yes. So one thing to call out is, so for instance, we have a rural track program. It doesn't have its certified definition of a rural track program, but it's out of a rural hospital, which gives us the definition of it being rural. So I would like for us to cast that big net of what is rural and what is not, and because some rules that are out there will take folks out of the designation because they're not designated, but they are rural in a rural hospital. So I can talk to folks. I don't want to take too much of the time, but I did want to call that out because that is a distinction.
Yes, thank you so much for that. We'll follow up and continue discussions about how to define community-based and or rural specifically as we go forward. So really appreciate that input. I think, Jeremy, I think your hand up is next.
Thanks. Yes. I did not introduce myself before. Jeremy Mees, adult primary care PA, work at WellSpace Health and immediate past president of Kappa. And to echo Catherine's point, I think these, and we, it was discussed the importance of the fellowships for NPs and PAs, postgraduate fellowships. They're really gaining a lot of steam right now. We have one where I work. Anecdotally, we're seeing a retention rate that we haven't seen in ever since I've been there, honestly. Down the street at Sutter, they've started a primary care fellowship for NPs and PAs. And I know it might be hard to tease out the quantity of those and how many graduates there are, so on and so forth, but perhaps even just the investment in those. I know HCAI itself gives a lot of grant money towards those programs. So I'm not sure if there's a way to look at all, various payers also are giving money towards that. So if we can't figure out, the amount of practitioners going through those programs, maybe just looking at the money amount going into it would be a good indicator of health, because I'm confident that this is going to help bolster our primary care workforce. And then the other really quick point is that AAPA, the American Academy of PAs, has survey data based, state-based, talking about both salary and practice specialty. So I'm sure probably if CMA doesn't, then AMA does, and NPs I'm sure do too. So I don't know, just putting it out there is something you probably already thought of, but.
Thank you. No, we really appreciate all of the additional input and suggestions for where we should look for more data. So please keep those suggestions coming, and any specific suggestions you have for sources that like where some of the PA licensure survey data might reside. We know where the California data is, but any other sources, please send them along. And Kevin, go ahead.
Hi, and following Jeremy's example, I'm sorry I didn't introduce myself earlier. I'm Kevin Rumback. I'm a family physician and I guess health policy troublemaker at UCSF. Again, I think really good work, folks, on developing these. I first thing, just to support where you're going with these, I think they're very well considered. I think as people have been talking, Raul, you brought up, I think there's been, HCAI has done such good work as part of the whole defining primary care spend that you first have to then decide who are truly practicing primary care. And this is where there's been a huge advantage over the self-reported specialty and just the licensing files, which, is true for PAs and nurse practitioners and others, as well as physicians, is to actually look at functionally what are people doing and where, so this is where you can distinguish let's say a general internist or even a family physician who is doing just hospitalist work, because you're just seeing billing claims coming from hospital settings rather than ambulatory settings. So this has been a huge step forward to be able to much more accurately measure who's really working, delivering primary care. So I think my sense is that's where you're going with this, right, Debbie and Miranda, is to really try to be as consistent with what HCAI has already established as a definition of identifying people practicing primary care using these more claim-based methods, correct? Yeah, just to confirm that, yeah.
Yes,
And-
that is correct. Yeah.
Yeah. And that also has another innovation in California, which is from the Department of Managed Healthcare, right? Which is maybe should be asterisked in here. It's not just the HPD, but right, it includes the Department of Managed Healthcare, right, which has the rosters that plans submit for who they identify as being available to serve as a primary care clinician for their enrollees. So it's an even, that's also been a really important filter. So I just want to, yeah, I think the more we can be completely consistent then across HCAI enterprises and this. And then the other thing, I mean, Raul, your point, which is really interesting, having been just at a Health Workforce Council meeting with HCAI last week, is now the licensing file is asking people to report their NPI, their National Provider Practitioner Identifier. Raul, you probably did that in the last round and things that they had, which now, so then that can be linked to the claims data. So now you could actually across, articulate and say, okay, we have special, they're whether people are really functioning in primary care, we can get from the claims data. Oh, and now we can link it for an individual with NPI to what they've reported on the license for their site of practice and their, hours that they're spending in their distribution, and start to then approximate FTEs. So I think HCAI is doing terrific work in partnership with the state licensing boards. So I think these are future directions to continue to refine this work with all these advances that HCAI and other agencies are making. And the final thing, I think Raul's also, just to, not to pick on Raul, but I think, the community-based, like teaching health centers or rural tracks, but I think there's maybe another slice on this of residency programs that are located in traditionally under-resourced areas. So that might be a rural hospital that's not technically a rural tract, but that's in a very, clearly low supply area that may qualify as a HIPSA or medically underserved area. And then the final thing HCAI is doing, I think, through its workforce programs is, the challenge for residency programs, and I think Jeremy with PAs or MPs is looking, what do people do when they finally finish their training? And that's to be able to track graduates through, data that I think the HCAI through its workforce programs are doing to say, here's the residency programs or the PA programs where the graduates really are working in primary care and in the under-resourced communities, which you could then almost come up with a category. We want to expand those residency programs and more of them whose graduates tend to work in the most under-resourced areas and really doing primary care. Again, that's probably for the long-range planning, but there's probably slices of cutting the residency programs. Diane's on this. I know Diane's very familiar with these kind of things, but to really look at actual performance of residency programs on downstream activities of their graduates.
Thanks so much for all that, Kevin. And it really highlights how much work across the different offices within HCAI is happening. And there's a lot of thought going into how we can kind of cross-pollinate, and that this snapshot can be an ongoing way to highlight the data as it becomes available. Thank you.
Yeah, I'm also seeing a great discussion in the chat, and I believe it was Catherine's comment saying we should definitely make sure we stratify this primary care clinicians by MPs and physicians and PAs, which we definitely plan to do. So just want to note that. And if there aren't any other discussion points from the group, I'll move on to our next steps for the workforce indicators. Okay. So similar to the investment domain, we'll be asking workgroup members to complete a survey on their evaluation of the proposed workforce indicators against our criteria, because we'd really love to get your feedback that way as well. And it's an opportunity to add more of your thoughts and other suggestions. We will use the results to inform the final list of indicators and then develop technical specifications for indicators that will be included in the 2026 snapshot. And with that, I will hand it back to Debbie.
Great. Thank you, Miranda. So before we wrap up for today, we'll just review some overall next steps. So as we mentioned, we'll be sharing a post-meeting survey with workgroup members to have you share your feedback on whether the proposed investment and workforce indicators meet evaluation criteria for inclusion in the 2026 snapshot static report, and also whether we should consider displaying them as interactive indicators in 2027. And by interactive, we mean indicators for which end users can select the stratifications or views of interest, such as toggling to primary care spending by insurance market versus by region. And before workgroup members complete this survey, we encourage you to review the guidance on evaluation criteria and the rubric that we'll send out along with the survey. And so HCAI will review all the survey results and share them with you, and then we'll continue with our review of 2026 primary care snapshot indicators for the quality, access, and equity domains. Our next meeting is on Wednesday, May 13th, and we look forward to seeing all of you then and to getting your feedback in the meantime. So again, thank you all for the really robust discussion today, including in the chat, and we're really looking forward to continuing this work in May. Have a wonderful day.